Hi, everybody. I missed you guys this week, but welcome to our Dysrhythmias lecture. This is actually a good lecture to have recorded because you can refer back to it as you study. This is one of those topics that requires quite a bit of time on your own to practice reading cardiac rhythms so that you understand how to do it. So it's nice to have this to refer back to off and on. The content in this lecture relates to chapter 35, not chapter 36, so just make a note of that. So dysrhythmias are defined as abnormal cardiac rhythms, and your ability to rapidly assess these abnormal cardiac rhythms, as well as your patient's response to these rhythms, is a critical nursing competency that you'll use pretty much every day in your practice. This is a picture of a 12-lead EKG. I'm sure you guys have seen these in clinical. The EKG tracing basically represents the electrical activity that occurs when the sodium and potassium ions switch places in the heart. The atrium ventricles contract and they depolarize and then they repolarize. This is what it looks like in an electrical setting, okay? You will not be learning 12-lead EKGs today, but I wanted you to at least see them, see what one looks like. The importance of a 12-lead is that we're looking at the heart from multiple different angles. So, and depending on where the damage is in the heart, we may not see any abnormalities in one section, and in another section we'll be like, oh no, look at this, we can see this really well over here. So it's the reason that when someone's having chest pain, we call for a 12 lead because we want to see all of these different angles, okay? When you call down to telemetry at the hospital, or when you've got someone that you're monitoring and you can look up at their rhythm, you can usually see one lead. If you're in ICU, you might see a couple, but you're not going to see 12 leads. Usually, if you call down to telemetry, they're monitoring lead 2. Sometimes one of these V leads. It really depends on the rhythm, what we want to see and what we can see the best, which lead we can see the best. So let's look a little closer here. When you're assessing a cardiac rhythm, the first thing you need to do is understand what it's telling you. Basically, you have time across a horizontal plane and voltage across the vertical plane. It's composed of large and small boxes. These large boxes are 0.2 seconds, and there are 300 of these in a minute. The large boxes are composed of 25 smaller boxes, 5 across. So these small boxes are 0.04 seconds each. A standard rhythm strip is 6 seconds. You'll usually see these little markers that tell you when 3 seconds has occurred. So you can see this is a 6-second rhythm strip here. So here's a 6-second rhythm strip. The first thing you're going to do when you're assessing a cardiac rhythm is you're going to determine if that rhythm is fast, slow, or normal in rate. Fast, slow, or normal. Now, we all know that the most accurate way to determine a rate is to count it for a minute. And we also know that in an emergency, we're not going to stand there and count the heart rate for a minute. It just takes too long. We're going to count how many beats we have in 6 seconds, and we're going to multiply it by 10 to get an estimate. And the quickest way to do this is to count the number of R waves in a 6-second interval. The R wave right here represents the ventricular contraction. So basically this is giving us a ventricular rate. And so we're going to count here. It looks like there are 8 R waves, 8 R's in our 6-second interval. We multiply that by 10 and we have a rate of about 80. Now, are we probably off a little bit? Yeah, we probably are. But are we close? Absolutely. We're in the ballpark. We know this person is alive. We know they're not too slow. We know they're not too fast. We quickly determined that. Another way that I've used often in my nursing career that is also in your book, it's not quite as quick, but sometimes it works better depending on your rhythm. Do you remember I told you these large boxes here? These large boxes, there are 300 of them in a minute. So you look at the R waves. You've got an R wave here. If you had another R wave right here, that would be a rate of 300 because there's one box between the R waves. If there were two boxes between the R waves, your rate would be around 150. 3, it would be around 100. 4, it would be around 75. So you can see, using that method, our rate is somewhere between 75 and 100. It's right in the middle, so I'm going to say maybe 85, maybe 90, somewhere in there. Again, not completely accurate down to the beat, but pretty close. And it gives us an idea of whether or not our patient is okay, right? So again, the quickest way is to use this 6-second interval. Depending on your patient and the type of rhythm they have, you may want to use the method where you count the big boxes. Both will work and both are fairly quick. So let's talk about normal just for a moment. I know you guys know this, but a quick review. In a normal heart with no damage, the sinoatrial node, SA node, acts as the pacemaker of the heart and generates an impulse of between 60 and 100 per minute. That impulse generated by the SA node goes through the internodal pathways down to the AV node, the atrioventricular node. The atrioventricular node is the backup pacemaker, and sometimes we'll say someone's in a junctional rhythm when the AV node or the bundle of His has to take over generating impulses. And when that happens, then your rate's going to be more like 40 to 60. So these impulses finish down through the bundle of His, into the right and left bundle branches, out to the Purkinje fibers, to the endocardium at the apex of the heart, and finally to the ventricular myocardium. Now, below the bundle area here are Purkinje fibers, and this tissue in here can generate a heart rate. We call that a ventricular rhythm, and that rate is only 20 to 40. So we don't really want the ventricles to have to take over. We're glad they do. We're happy for their service, but we really want the SA node or the AV node working. So that's sometimes why people will need a pacemaker, because there's been damage up here from a heart attack or something like that. So just so you understand, the normal sinus rhythm means that all of this is working fine and everything's going the way it should. One thing I wanted to tell you that's kind of interesting is the AV node, besides being the backup pacemaker for the heart, it's also the gatekeeper. We call it the gatekeeper for the heart because it limits the electrical activity that reaches the ventricles. In situations where the atria generate excessively rapid electrical activity, you've heard of AFib and probably you've heard of AFlutter. The AV node will limit the number of conductions of signals conducted down here to the ventricles. So say you're an AFib and your ventricles or your atria are beating at 300. They're just going crazy. They're fluttering away, fibbing away. If the AV node blocks 2/3 of those beats, then your ventricular rate will only be 100. And you'll actually have a decent cardiac output. Now these aren't going to be too effective up here. They're going to be not filling as well as usual, but your ventricular rate out to the heart will still be around 100, and you'll have a decent cardiac output. Now imagine if the AV node wasn't blocking that, right? Then you've got a ventricular rate of 300, and that is not compatible with a great cardiac output. So your AV node is really important because it blocks those extra impulses. So when you're listening to nurses or physicians at the hospital talk about AFib, they'll say AFib with a controlled ventricular response. What that means is you're in AFib, but your ventricles are responding between 60 and 100. It's a controlled ventricular response. When we start bringing in medications is often when it's what we call a rapid ventricular response, anything over 100 or anything that's asymptomatic, then that's AFib with a rapid ventricular response. So our AV node is not blocking as much as it should. You will find in folks who you've probably heard of Wolff-Parkinson's White, And that's a really interesting disorder because it involves an accessory pathway between the atria and the ventricles through something called the bundle of Kent. And what happens is that, just what I was just saying, is that all impulses are sometimes conducted from the atria to the ventricles. So people in Wolff, Parkinson's, White will experience extremely rapid heart rates that result in a great deal of hemodynamic instability because of that loss of cardiac output. In some cases, it can trigger ventricular fibrillation and sudden cardiac death. So a lot of times these folks need to either, if they're not controlled with antiarrhythmic drugs or drugs to slow their heart rate, they'll need some type of electrical procedure done to sort of kill those extra pathways through the bundle of Kent and slow their heart down. So just a little something to think about there. Interesting stuff. So the reason we reviewed all of that is because your next step after you determine if your rate is fast, slow, or normal is you need to determine if you have all of the parts that you need to show you that you're in sinus rhythm. So once you know if your rate is fast or slow or normal, then you need to see, do I have a P wave? This is a P wave before every QRS. Because to be in sinus rhythm, you have to have a P wave before every QRS, because the P wave is when the atria contract. The QRS is when the ventricles contract. Between the two of them, you have what's called the PR interval or PR segment. I hear it called interval more than segment. The PR interval starts at the beginning of the P wave and goes right here, right before the R wave goes up. The normal for that is 0.12 to 0.20. Remember, these little boxes are 0.04, so 0.12 is 3 of these boxes, and 0.20 is 5 of these boxes. So the reason the PR interval is important is because it tells us how long an impulse takes to travel from the atria down to the point where the ventricles start contracting, right before they contract. So the normal for the PR interval here is 0.12 to 0.20, which 0.12 is 3 little boxes and 0.20 is 5 boxes. So if it takes longer than that, we could have a block somewhere in there, right? Something isn't working well. It's having to go around a different area and it's taking a little longer. If it's shorter, the impulse might be originating further down in than the SA node. So if you have say a 0.08 or a 0.04, your P wave is right here. You could be generating your impulses. We call that a junctional rhythm a lot of times if we have a short PR interval, because a normal PR interval needs to be at least 0.12 to be coming from the SA node, to be originating there, and no more than 0.20, or we might have a block. The next thing you're going to measure is your QRS interval. And your QRS interval is measured from the beginning of the QRS complex to the end. So even though it goes up here, you're going to take your calipers and you're going to measure from here to here. And the normal needs to be less than 0.12. If it's greater than 0.12, if it's widened, you can have a disturbance in conduction in the bundle branches or in the ventricles, because remember, this is when the ventricles contract. So if they're taking a little too long to depolarize and contract, then there's some kind of block down in there in the ventricles. Then you have a T wave. The T wave is when the ventricles repolarize. They've contracted here, now they're repolarizing, okay? You don't see atria, this is the atrial depolarization. You don't see the atrial repolarization because it's hidden here in the QRS complex, but it does repolarize right here inside the QRS complex. So this is your ventricles contracting. This is where they repolarize. Now what we want to look at here is this little segment right here, the ST segment, because an elevated ST segment, you measure this from the S wave of the QRS complex to the beginning of the T wave, It represents the time between when the ventricles depolarize and when they repolarize. And if you have elevation or depression in this ST segment, it can be caused by ischemia, injury, or infarction. And you need to know the ST segment and what the different elevations or depressions, what they mean. So make sure you study that in the book because this ST segment should be even with what we call the isoelectric line. It shouldn't be up, it shouldn't be down. The other thing that you'll notice with your T waves is if they're, study your T waves because these should be upright. They should not be too tall, they should not be peaked. All of those things can mean different things like elevated potassium. Usually it's electrolyte imbalances, things like that. So make sure you understand what can cause the ST segment to be elevated or depressed and what can cause the T wave to be unusual in some way. So sinus bradycardia, you know how we look at the heart and we say, is it fast, slow, or normal? When we have sinus bradycardia, we'll have a rate of 60 or usually less than 60. I don't agree with this slide. I would say 59 or less for those of you taking tests. Just know that the sinus node will usually discharge between a 60 and 100, and anything less than 60 we're going to call sinus bradycardia if it's sinus. Normal rhythm, this can normally occur in athletes and when we sleep, and it can also be seen in the elderly. Sometimes we'll see it in people who are on beta blockers where their heart rhythm's being slowed by medication. And here's an example of sinus bradycardia. You can see that if we were going to count out our 6-second strip, this strip isn't quite 6 seconds. We're going to pretend like it is. If it was 6 seconds, we would have a rate of about 40. So you can definitely see how much slower it is. You'll see sinus bradycardia in people who have hypothermia. It's the body's natural response to try to slow everything down a little bit. Anyone who's getting any type of parasympathomimetic drugs. Anybody who's got increased vagal tone. This is why we tell people don't strain, because they're going to stimulate that vagal nerve and cause their heart rate to drop. So these are things that we see sinus bradycardia with. You'll also see it in disease states, anybody with hypothyroid, if you've got any kind of brain injury with an increased intracranial pressure, any kind of jaundice, obstructive jaundice, or an inferior wall MIs are known for bradycardias. So the significance of sinus bradycardia is that you can definitely get a reduced cardiac output in someone who's got bradycardia and they're not an athlete where they're getting a nice big home volume with each beat. Their cardiac output can drop. So in symptomatic bradycardia, we'll give them atropine. A pacemaker may be required depending on what the underlying cause is. Sinus tachycardia is when we have increased heart rate greater than 100 beats per minute. This is from the result of vagal inhibition. And I'll show you here on the next slide. We'll see an example of sinus tachycardia. And here's an example of sinus tachycardia. The reason that this is sinus is because you do have a P wave before every QRS. This is kind of a rough rhythm because you can't always see the P wave real well, but you can see a little indentation there. This almost looks like you can't see it, but for the most part, this is a sinus tachycardia here, an example, because you have a P wave before every QRS, but it is a rapid rate. So sinus tachycardia, exercise, obviously you want your heart rate to go up with exercise. You'll see this with hypotension or hypovolemia, someone who's dehydrated. This is classic. You'll give them fluids and watch their heart rate come down nicely. Disease states, certain MIs can cause fast heart rates, and also in CHF you can have tachycardia as well. So the clinical significance of sinus tachycardia is that, this classic signs of hypotension and hypovolemia is with that dizziness that you can get. Your blood pressure can drop, and it drops your cardiac output. It drops perfusion to your vital organs. So you've got to get your fluid volume back up and slow that heart rate down. It's also causes an increased myocardial oxygen consumption. And that can be very dangerous in the presence of an MI. So you want to get that heart rate down to improve your cardiac output and to decrease the oxygen consumption. In the presence of an acute MI, you can definitely worsen the size of the infarct. You can definitely cause more tissue damage. This is why they'll put people on drugs to decrease their heart rate, generally because the more your heart has to work, the more that infarct size is going to grow. So they found that if they administer drugs to decrease the heart rate, decrease the workload on the heart, they can preserve tissue while we're hopefully getting things fixed. And this is why our beta blockers are so important following a myocardial infarction, is because they reduce the heart rate and they reduce myocardial oxygen consumption, all of which keeps the heart from remodeling following a myocardial infarction and becoming enlarged. So a premature atrial contraction, you'll hear these called PACs. These originate from an abnormal, or ectopic is another word for abnormal, focus in the atrium. Any location other than the SA node is basically an ectopic location. So you will see premature atrial contractions. The P wave will look a little different. Sometimes you'll see that it's coming the beat will come a little early. Sometimes you'll really feel these if you drink a lot of coffee. They feel like you're going to die, but they're really quite benign unless there's too many of them. So we'll show you a picture here in a minute. And here's that picture. You can see our P wave before every QRS. So we got kind of a widened QRS here, don't we? P, QRS, and then boom, different P. That means it's coming from somewhere else in the atrium. We're still conducting it down to the ventricles. We're still getting a ventricular response, but it is earlier. This isn't quite a complete pause. Usually you'll see when you have PACs that your next beat will hit exactly where it should have had this beat been normal. To me that looks almost like a complete compensatory pause, but I guess if I got my calipers out, it is slightly incomplete. But just know that this is a PAC. It's just occurring a little bit sooner. The beat's coming a little sooner and it looks different. And PACs can occur in almost anyone, from many, many things. Emotional stress, if you've ever felt your heart skip a beat. For me, it was the caffeine. If you've got some kind of infection, anything that's causing you to have any kind of stress on your heart, your PACs will kick in. Valvular heart disease, COPD, they are generally benign, like I said. So in you or me, when we're just having too much caffeine or we're a little bit stressed because of a test in nursing school, a PAC in a healthy heart is benign. It's not something we worry about. In people with heart disease, frequent PACs can become a problem. They can indicate that your heart's a little bit, the automaticity of the atria is enhanced a little bit. It can warn of possible supraventricular tachyarrhythmias. And it can initiate those. And I believe on later slides I'm going to show you SVT, so you'll see what those are. So just you'll know what those are. I'll show you. So again, for PACs, for you and me, the doctor's going to tell you to cut down on your caffeine, to take some meditation classes. For someone with cardiac disease who's starting to have some issues with frequent PACs and starting to have some symptoms, frequent palpitations, uncomfortable palpitations, they'll give them some beta blockers to decrease the number and frequency of PACs. So paroxysmal supraventricular tachycardia is exactly what it sounds like. Paroxysmal means that it's an abrupt onset and an abrupt stopping, so it starts and stops abruptly. Supraventricular means that it originates above the bifurcation of the bundle of His, and it's a run of repeated premature beats that are initiated by PACs usually, and these usually are PACs, but it's so fast that we can't really tell. All we can tell is that it's above the bundle of His. We can tell that it's not originating from the ventricles, and let me show you how. Okay, so this looks ugly, but this is what we call paroxysmal supraventricular tachycardia. The way that we know this is above the ventricles is because our QRS is normal. We have a normal QRS. Remember, it's supposed to be less than 0.212, and 0.12 is 3 boxes. So these QRS complexes, even this wider one here, are under 3 boxes. They're under 0.12. So we know that this is originating above the ventricle somewhere, but we can't really tell where. We can't tell because we can't see the P wave. It's too fast. So we can't tell if this is junctional. We can't measure our PR interval, right? Because we can't see it. So we can't really tell where this is coming from, but we know it's above the ventricles. So we're going to call this supraventricular tachycardia. It's basically we're backing out. We're saying we know it's above the ventricles. It's what we call a narrow complex tachycardia. And a narrow complex tachycardia is above the ventricles. So we know it's something to do with the atria. And it came on suddenly. And that's what we're telling you. It's a paroxysmal supraventricular tachycardia. This is one of those rhythms that we'll see in Wolff-Parkinson's-White, and we already talked about this a little bit. It's some kind of tachycardia. It's occurring in the atria, and it's being too many beats are being conducted down to the ventricles, so we've got a tachycardic syndrome, and we want to get this fixed because we don't want this continuing. Because when you've got a tachycardia, you're not going to get adequate cardiac output. Again, we see this with overexertion, emotional stress, but we can see it with coronary artery disease or toxicity of certain drugs, and also with the use of stimulants. If you're taking any kind of recreational drug that causes your heart rate to pound fast, we see this sometimes in people who are drinking a lot of Red Bulls and like me, too much coffee. So that's the clinical associations in general, besides Wolff-Parkinson's-White. So if you have an episode where the heart rate stays over 180 or greater for a prolonged amount of time, it's going to decrease your cardiac output, which is going to cause hypotension and myocardial ischemia. You're going to use vagal maneuvers, and you're also, vagal maneuvers, if they don't work, you're going to give some medications. Adenosine is the drug that you're going to give for paroxysmal supraventricular tachycardia, also called narrow complex tachycardia. The goal is to stop the heart rate, basically stop it, all those abnormal ectopic areas of the atria that are causing beats to be conducted and causing that tachycardia. You want to stop them so the SA node can take over. Other times you're going to have to cardiovert, especially if they become unstable. And again, your goal with cardioversion is the same as with the adenosine. Your goal is to stop those abnormal beats and allow the SA node to take over and hopefully start regulating your heart at 60 to 100 again. Know that with Wolff-Parkinson's-White, you want to avoid giving digitalis and calcium channel blockers because these can cause hemodynamic collapse in those folks. With Wolff-Parkinson's-White, most people will be able to tell you that they have that disorder and that they know about it because it's usually diagnosed in childhood. So just note that. We're not going to go into it a lot because you don't see it much. But again, you may have to, these people may have to have an ablation done. They go in and they basically kill certain parts of the heart that are causing these abnormal tachycardias. And depending, what they do is they do electrical studies that show them where in the atria that the heart is beating abnormally from, where those impulses are coming from, and they go in and they destroy those areas to stop the paroxysmal supraventricular tachycardic episodes. Atrial flutter is another atrial tachyarrhythmia that occurs in the atria, obviously. This is characterized by a sawtooth-shaped flutter waves instead of P waves. They're usually quite regular, these sawtooth-shaped flutter waves, and you have a slower ventricular response than you do with atrial fib. I think I've got a picture here. And here's our picture of atrial flutter. Basically, you've got, it looks like either, I think, a 3-to-1 flutter here, because this one, there's a flutter wave hidden in the T wave. So I think you've got like a 3-to-1 flutter. And what that means is you have these flutter waves. It's 3-to-1, 3 flutters to 1 QRS. Flutter is called a regular rhythm because your ventricular response is regular. You see your QRS here? If you go from your R to R, you'll find that this is nice and regular. So it's a regular ventricular response. And that's one of the hallmarks of atrial flutter, is it's fairly regular, and that means you're going to have a, probably a decent cardiac output with this. And this is what you see atrial flutter with. Often you'll see this with mitral valve disorders, chronic lung disease, cardiomyopathy, sometimes with pulmonary embolus. If you have high ventricular rates with the atrial flutter, your cardiac output can become decreased. This can cause you to go into heart failure. You do have an increased risk for stroke because of the risk of thrombus formation in the atria. Basically, your atria aren't, they're not, blood is sitting in there just like it is with AFib, and you can develop clots. So any kind of atrial flutter that's been going on for more than 48 hours will start Coumadin or some kind of anticoagulant. So we're actually not all that worried about the atrial flutter. We're more worried about the ventricular response. So we want to keep that ventricular response slowed down. Sometimes, again, we'll do electrical cardioversion if these folks are having symptoms. We want to slow it down so their cardiac output is maintained. So here's our usual suspects that we can use to control the ventricular rate. Sometimes we'll use something like amiodarone, an antiarrhythmic drug, to convert the atrial flutter to sinus rhythm or to maintain a sinus rhythm. We can do ablation, and again, we can cardiovert in emergency situations. So atrial fib is basically a total disorganization of atrial activity. There's no effective atrial contraction. It can be chronic, it can be intermittent. You'll see both kinds. So this is kind of interesting because you've got looks like a little bit of flutter that's deteriorating into AFib, and you can see there's no identifiable P waves here, right? They're just this irregular pattern here. There's nothing you can read. That is AFib. The classic way to determine if you've got AFib is if you can't really find a P wave. You think, oh wait, is this a P wave? And you start to count it, like, I don't know, no, look over here, there's no P wave. And then you measure your R to R, and it's irregular. AFib is an irregular rhythm. You have irregular ventricular response. That's a classic way to identify fib. Flutter, one thing I wanted to tell you about flutter is one reason it's more regular, you had those nice regular R to Rs with the flutter, is because flutter generally originates from the same ectopic focus in the atria, right? It usually occurs in a heart that's diseased, but it's from the same ectopic area. Over here in fib, you've got multiple different areas. It's coming from all over. The atria is just, it's fibrillating. It's just shaking like a leaf, like my mother used to say, and it's going to be very irregular. So atrial fibrillation, like atrial flutter, atrial fib never occurs in a healthy heart. Atrial flutter rarely occurs in a healthy heart. You'll usually have some kind of underlying heart disease, some kind of valvular, rheumatic heart disease, cardiomyopathy, CHF, and even in the presence of pericarditis. But again, you can see atrial fib in the presence of caffeine use. I've seen this definitely with lots and lots of Red Bull in young, healthy people. And there's nothing worse than getting cardioverted when you're about 30 because you've had too many Red Bulls. But it happens. So you can see it in electrolyte disturbances, and that's usually the young people that we'll see is somebody who's been out drinking and they've had their Red Bull, so they're dehydrated, they haven't been eating properly, and then they put caffeine on top of it, and you're in here getting cardioverted. But it usually cures their Red Bull habit. But definitely you can also see it in cardiac surgery, and some other types of issues or disorders. And again, the significance here is that if you have atrial fib with rapid ventricular response, we kind of talked about this earlier, you're going to get a reduced cardiac output. So your goal, some people who have chronic AFib, you're not necessarily trying to get them out of the AFib, you're trying to get them to a controlled ventricular response, like we talked about earlier, because you're watching for their symptoms and their cardiac output. There is a high risk of stroke with atrial fib because of the formation of clots in the atria. These can pass to the brain, causing a stroke. It's 5 times in atrial fib, 5 times increase risk for stroke. And if you have a structural heart disease, some kind of valve disorder, hypertension, and you're over the age of 65, your risk is even higher. These folks need to be on Coumadin to prevent stroke, and I will tell you the most dangerous time, and write this down, the most dangerous time for anyone who is in atrial fib is if they're going down for a cardioversion and they are not anticoagulated. You've got them downstairs, you're putting them on the pads, and you're doing a cardioversion to hopefully put them into sinus rhythm. And if they are not anticoagulated, they are at the highest risk of stroke. Because think about what happens. You've got your fibrillation going on, you've got your clots building up there in your atria, and then you take a person down for a cardioversion and you boom, put their heart back in sinus rhythm. Well, now their heart is nice and strong, and it goes huff, whoop, and it pushes those clots right out and causes a stroke. That has happened to nurses before. Not to me, thank God, but know that if you've got someone in AFib, they need to be on a blood thinner. And they need to be on a blood thinner before they go down for any kind of cardioversion, particularly if they've been in atrial fib for more than 24 hours. So just know that you don't want to send your patient down for any kind of cardioversion who's in AFib unless they are anticoagulated. You need to let the doc know. And I'm not going to read this slide. This is the same type of treatment that we've seen for the other narrow complex tachycardias. So here you are with your drugs, and your goal is to decrease ventricular response. We do again use either our antiarrhythmic drugs like amiodarone or cardioversion to convert from atrial fib to normal sinus rhythm. And again, you want to have your anticoagulants on board, usually 3 to 4 weeks. If they're stable, they'll send them home. And let them be on anticoagulants for a while and bring them back for either a medical or electrical cardioversion. So I talked a little bit about narrow complex tachycardias, those an AFib, those kind of atrial-based tachycardias that we get. Now we're going to talk a little bit about heart blocks. A first-degree AV block is when every impulse from the SA node is conducted through the AV node to the ventricles, but the duration is prolonged. So you know how I said your PR interval is usually 0.20? A first degree block is any PR interval that is greater than 0.20, meaning that it's taking a little longer for that impulse to get down through the AV node and to the ventricular response. So here's our example of a first degree AV block. Our PR interval is prolonged. Remember, it's supposed to be no more than 0.2, which would be one of these big boxes. So it's definitely prolonged PR interval, which means that it's taking a long time for our impulse to travel down through the AV node. It's being blocked there at the AV node. But we still have a QRS complex, and we have a QRS complex after every P wave. So it's a first degree block because the PR interval is prolonged, and because, even though it's prolonged, we have a QRS following every P wave. We don't treat first degree AV block as long as, pardon me, usually it's asymptomatic, you've got good cardiac output. It can be a precursor to higher degrees of AV block, and we're going to talk about those next. So a second degree AV block type 1 is also called a Wenke block. The way to remember that is type 1 Wenke widen. Type 1 Wenke widen, okay? A second degree type 1 block is called a Wenke block, and it is characterized by a gradual lengthening of the PR interval, a gradual widening of the PR interval, and it occurs because of prolonged AV conduction times. It's most commonly at the AV node. It can occur below that, but usually it's at the AV node. So you had your first degree where your PR was lengthened, but you had a QRS following every P wave. Now we're going to talk about your second degree type 1 block. Like I said, it's also called a Wenke block, and it is characterized by a gradual widening of the PR interval. And we're going to show you an example. So here it is, our second degree block, type 1, Wenke block, our P wave widens. If you look here, we've got our PR interval widens. See, we got it here. It's right here. We've got a QRS. This one's a little bit wider, still have a QRS. This one's even wider, still have a QRS. And this one, if you could see over here, you would see that it dropped the QRS. So your second degree type 1 Wenke block, the PR gradually widens until you finally drop your QRS complex. So this is not sinus rhythm because you don't have a QRS complex following every P wave. So first degree, you'll often hear called sinus rhythm with a first degree block because every P wave has a QRS. Second degree, type 1, you will not hear called sinus rhythm because every P does not have a QRS. You've got widened PR intervals with a dropped QRS. Okay? So this is usually caused by an inferior wall MI or myocardial ischemia. This is usually something we watch closely because it can be a sign of an impending significant AV conduction disturbance, meaning that this could progress to a higher, a more dangerous type of block, which we're going to talk about. So our second degree type 1 Wenke block that's characterized by widening PR intervals until we finally drop a QRS complex is, if it's symptomatic, we may just watch that, or pardon me, if it's asymptomatic, we may just watch them, monitor them, make sure that they're maintaining their cardiac output, check their blood pressure, make sure they don't have symptoms. But we are going to have our pacemaker, our transcutaneous pacemaker on standby, which basically means we're going to have our patches on them, we're going to have our code cart nearby, and we're going to keep a close eye on them. If they're symptomatic, we're going to give them atropine or start the pacer. But basically, we're watching this rhythm closely because it could very easily deteriorate into a more serious block, which we're going to talk about shortly. So our more serious block is still a second degree AV block, but is a type 2, second degree type 2. Now in a second degree type 2, there's no widening of the PR interval. No widening. We just see a nice normal P, QRS, P, QRS, P, QRS, P, nothing. This almost always happens when a bundle branch block is present, and just a certain number of impulses from the sinus node are not being conducted. We get no warning. There's no none of the widening that's going on with the type 1. So this is a much more serious block. And let me show you a picture of it. So here's our type 2 or second degree type 2 block. We just got a nice PQRS. Ooh, that doesn't look good. PQRS. Let's see, their P or PR interval is the same. And then boom, nothing's conducted. And then back to our normal PR interval with the QRS. But we're dropping a beat with no warning. Second degree type 2, this often progresses to a third degree block. This is someone who we're going to need to get them paced because they can often develop hypotension, more myocardial ischemia, along with a decreased cardiac output. And we don't want this to progress to a type 3 block. So these folks, we are definitely going to give them some atropine. We want to increase their heart rate until we can have a pacemaker placed. We're also going to have some kind of temporary transcutaneous pacemaker there and ready, and probably we're going to be using it on these folks. Finally, we have a third degree heart block, and this is a complete heart block is another word that you'll hear for this. Basically, you've got no impulses that are being conducted from the atria to the ventricles. There's just complete dissonance. You're going to see the ventricles firing and you're going to see the atria firing, but they're not going to be together at all. They're divorced. In other words, the others were considering a divorce, and in third degree heart block, the atria and ventricles have completely dissolved. They have completely dissolved the marriage, and here is our divorced couple now. We've got our atria, what we call marching out. You see how that's nice and regular? Your P waves are regular. And your QRS, if you saw another one, you would see that your QRS would be fairly regular as well, because your ventricles and your atria are both doing their own thing, but they're not doing anything together. So you don't have any cardiac output with this, or very, very low cardiac output. Because they're just not working together. Your ventricles are contracting. They may or may not be filled with any kind of blood from the atria. So they're both just doing their own thing, absolutely unrelated to one another. So this is serious. You're going to have a very low cardiac output. Your heart's going to be failing. You're probably going to pass out from syncopal episodes, from severe bradycardia, possibly periods of asystole. This is another emergency situation. You're going to need to pace these people. You're going to have to put your temporary pacemaker on there until you get someone in to emergently put a permanent pacer in. You're definitely going to be giving drugs to increase that heart rate and do anything you can to support the blood pressure until you get that pacemaker placed. So we started talking about the atria, and then we talked about conditions that affect conduction from the atria to the ventricles, and now we're going to talk about abnormal beats and dysrhythmias that occur in the ventricles. First off, we've got our premature ventricular contractions. This is basically a contraction that originates somewhere in the ventricles that's abnormal. You're going to see a premature QRS complex. You can have all types of PVCs. They can be multifocal, unifocal. What that means is when they're unifocal, they're from the same area of the ventricles and they will look the same. When they're multifocal, they will be from different areas and they'll look different. Ventricular bigeminy is when every other beat is a PVC. You can have sinus rhythm with underlying bigeminy. So you can have a sinus beat and then a PVC and then a sinus beat and then a PVC, and that's bigeminy. You can have trigeminy, you can have couplets or triplets. Couplets are 2 in a row, triplets are 3 in a row of PVCs. And here's some great examples for you. This top one, you see you've got a sinus beat, PVC, sinus beat, PVC. So you've got, these are multifocal because they don't look the same, right? And probably every third beat, but we're not sure because we don't have enough to look at. But for sure, they're multifocal PVCs. Down here, you've got a couplet. You've got two together here, and then a regular beat, and then another regular beat, and then off we go into 4 beats of VTach before we go back into our sinus rhythm. By Gemini, here's your every other beat is a ventricular beat, or a PVC is every other beat. But these are unifocal. See how they look alike? So you're in ventricular by Gemini, but it is unifocal. Trigemini is every third beat. R on T is an important phenomenon to know about because it can put people into VTach very quickly. It's basically when your PVC hits on the T wave, when the ventricles are repolarizing. If you have an impulse come through that hits on that, it can send a person into VTach, so just know about that. Trying to think. One thing I want you to know about a PVC is that they are wide complex. Now remember those atrial tachycardias and those atrial strange rhythms, paroxysmal tachycardia, all of those were called narrow complex tachycardias, narrow complex rhythms. And that's because their QRS complexes were narrow, just like a normal one. With PVCs, you can see that QRS complex is widened. It's wider than the 0.12 that we'd like to see. So this is a wide complex issue. That will become important to you someday when you learn ACLS, because you treat narrow complex tachycardias and wide complex tachycardias differently. So probably the most common thing we see with PVCs is when people have hypokalemia. We see that in the hospital quite a bit. If someone starts throwing PVCs, the first thing I'll usually do is ask for a potassium level. Also, it can be with stimulants, MI, mitral valve prolapse. Usually a PVC is a benign finding in you and me with a normal heart. Maybe we're a little dehydrated, we went for a run and our potassium is a little low. In heart disease, PVCs can significantly reduce cardiac output, can cause angina, heart failure, and in ischemic heart disease or an acute MI, it means that your ventricles are getting very irritable and you're at high risk for VTach. You will also see PVCs when you have reperfusion of a coronary artery occlusion or clot. If you've had someone who's gone to cath lab and they've had a stent put in, or they've had some kind of thrombolytic therapy following an MI, and they've opened up their coronary arteries, you will sometimes see premature ventricular contractions following reperfusion therapy because their heart's irritable. You're waking up tissue that had been dying, and it's waking up and it's irritable and cranky, just like I am in the morning. And so it's fairly common in the first 24 hours following some kind of reperfusion therapy to see PVCs. Not something we get too concerned about. We just kind of watch them and watch the patient because we're expecting that after certain types of procedures. Same type of thing, we assess our patient. If they're asymptomatic, we may not do anything. If they're just having single unifocal PVCs, we're going to watch them. If they become multifocal or more frequent, or they become symptomatic, we're going to then look at our drugs. And it's our usual suspects, our beta blockers, amiodarone. Some of our older drugs we used to use were lidocaine and procainamide. I have not seen those for many years. You used to use them all the time, but once amiodarone came around, that's usually what you'll see. Ventricular tachycardia is defined as a run of 3 or more PVCs. They can be monomorphic, they can be polymorphic, they can be sustained or non-sustained. This is a life-threatening situation because of the decreased cardiac output and the possibility of deterioration into VTAC, sustained VTAC, or VFib. Having said that, I've seen people have runs of 6, 7, 8 beats and they don't feel a thing sometimes. You're still concerned about it and you still need to call the physician, and probably you're going to be giving, I bet their potassium's low, you're going to be figuring out what's going on. But sometimes people don't really feel them, even though they're completely not getting much cardiac output at that point. So anything greater than 3 is VTAC. And here's a picture of VTAC. You can see it's very wide, complex tachycardia. That is from the ventricles, and you've got no cardiac output right now. So there you go. Again, acute MI, significant electrolyte imbalances, coronary reperfusion, following any kind of thrombolytic therapy or any kind of reperfusion therapy. You'll see it in some CNS disorders. Generally, you're going to check your electrolytes first. You're going to check your patient first and make sure they're stable. Check their blood pressure, heart rate, make sure they're conscious. See if they have a pulse. Some people do, some people don't, and we treat them differently with a pulse or without a pulse. And again, you're going to expect some, you may see some ventricular tachycardia with coronary reperfusion therapy. So you do see VTAC sometimes in patients with no evidence of heart disease. Sometimes you'll find some kind of congenital disorder or some kind of underlying electrolyte imbalance that we didn't know about. It can cause a severe decrease in cardiac output, and you can go into cardiogenic shock. So VTAC, believe it or not, can be hemodynamically stable. We call this VTAC with a pulse. And these folks can often be what we call cardioverted medically with either procanamide, amiodarone, or lidocaine. But I will tell you that VTAC that's stable doesn't stay stable for long because they don't have any cardiac output. And if they're stable, it's because you caught them very quickly and you ran back to the room with the drugs and you were able to give it in time so that they didn't need to be cardioverted or defibrillated. But VTAC that is hemodynamically stable will definitely deteriorate to unstable VTAC fairly quickly. We'll talk about cardioversion on the next couple of slides here. VTAC that's polymorphic, we're going to consider magnesium. It's often a low magnesium level. We're going to be pacing, and we're probably going to be looking at some IV beta blockers. For the polymorphic VTACs, we're going to look at discontinuing any drugs that might be prolonging the QT interval, and we're going to be looking at possibly unsynchronized cardioversion. Now here's where I wanted to say with a monomorphic VTAC, you can synchronize cardiovert because you have a nice regular QRS. It's a VTAC, but it's nice and regular and it always looks the same. So your defibrillator can sense that nice, regular, always the same PVC, and it can sync to it. That's always the best thing to do, is to sync if you can. With polymorphic VTAC, you are not going to be able to sync. You're going to have to do an unsynchronized cardioversion because it's not going to look the same. It's going to be irregular. Your defibrillator will never fire if you try to sync it. So just know that with irregular rhythms, it is more difficult to sync. Now with AFib, even though that's an irregular rhythm, we do sync with that because we don't want to accidentally hit that QRS with our electricity and cause a person in AFib to go into VTAC. So just know that generally with an irregular, wide, complex tachycardia, you're going to have to do an unsynchronized cardioversion, or a defibrillation is more commonly what we see. So VTAC without a pulse is treated the same way as VFib. We're going to do a rapid defibrillation in order to close down that rhythm, stop that rhythm, and get the heart to restart at the SA node. That is our first line treatment. Again, VTAC is associated with acute MI or reperfusion of the myocardium after thrombolytic therapy or angioplasty. VFib, basically, it's like, you know how in AFib, the heart is just fibbing away, just in there's no effective contraction, no real opportunity for cardiac output to happen. It's an undulating, just like I want to say like a seizure of the heart. That's the word I'm looking for. Basically, VFib, you've got no pulse, you've got no effective contraction, no cardiac output. You are basically dead, and we need to bring you back to life. So this is an example of VFib, although you'll often see it even more disorganized than this. And again, I shouldn't have said you're dead with VFib. You have no cardiac output with VFib, and you are on your way to being dead. We are doing compressions. We are doing everything we can to get your heart back into a regular rhythm. The very first thing we're going to do is defibrillate, 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 because we really need to get this rhythm stopped so that your heart can start back up into an organized rhythm and give you some life giving cardiac output. So there are lots of reasons VFib occurs. Again, any kind of damage or disease of the heart. You see this with electrical shock. People who have been hit by lightning, this is what takes them out. You see this in high potassium levels. Some drug toxicities will cause this. And sometimes we see this during our heart catheterization procedures or with or after coronary reperfusion therapies. Now, we are not expecting this following coronary reperfusion therapy. This is something we need to treat, and we don't want to happen. In VFib, we do not have a pulse. We have no breathing. The person may be having seizures. They're unconscious. If left untreated, they will die. They are very close to death right now. So this is immediate CPR and ACLS with drugs and defibrillation. If your defibrillator is there, you're going to get that defibrillator on the chest immediately to try to convert this back to a good rhythm before this deteriorates. Once VFib deteriorates into asystole, you have much higher mortality rates. So the faster you can get these people defibrillated and hopefully get a regular organized cardiac rhythm back, the higher chance they have of living. So if you're in the room, you're going to start CPR and scream as loud as you can for somebody to grab that defibrillator. If you have the defibrillator, you're going to use it right away. So pulseless electrical activity is another rhythm I want to tell you about. This one confused me so much when I was a student because you will have electrical activity. Sometimes it looks like sinus rhythm up there. But there is absolutely no mechanical activity of the ventricles and the patient has no pulse. So basically you've got an electrical thing on your monitor, you're looking at it and it looks great, but you've got no pulse. So if you have no pulse and no mechanical activity of the ventricles, you have no cardiac output. So PEA is treated exactly like asystole or exactly like asystole. We get on the chest, we start doing compressions while we figure out the underlying reason. And this is often a little bit strange at first because you're looking up there and you see this great cardiac rhythm. It may even be sinus rhythm, but you've got no pulse. So you have to treat it exactly like, you need to do compressions and get some cardiac output going. With this, we look at things, we call it the 4 H's and the 4 T's. Common causes for this are hypovolemia, hyper or hypokalemia, pulmonary embolus. You can have an MI, a drug overdose. So you're going to be, like I said, doing CPR. You're going to intubate. You're going to make sure they have an IV, and you're going to give them epi, and you're going to correct the underlying causes. The 4 H's and 4 T's that I was referring to, you've got hypovolemia, hypoxia, hydrogen ion, which that means they could be acidotic. You could be hypothermic. You could have high or low K. The T's are things like toxins, drug toxicity, cardiac tamponade, tension pneumothorax, trauma, or clots, which we call thrombosis in our 4H's and 4T's. So a couple of things about defibrillation and cardioversion. First, defibrillation. We want to get on the chest immediately and defibrillate when people are in VFib. It's the most effective method of terminating it. Ideally, we want to get our defibrillation going within 15 to 20 seconds of when we see that arrhythmia. We basically pass direct current through the heart to depolarize the cells, and the intent is to allow the SA node to resume its normal role as the pacemaker of the heart. So cardioversion is the therapy of choice for hemodynamically unstable ventricular rhythms or supraventricular tachyarrhythmias. These are more organized rhythms than what we see in VFib, which is where we're going to defibrillate immediately. These rhythms are more organized, so we're going to cardiovert. They deliver a countershock during the QRS complex, and our goal is the same, to allow the SA node to take over again. We can also do these on a non-emergency basis for things like AFib that's chronic or has been, we've sent them home to have their anticoagulants and now they're back in and we're going to cardiovert them. So cardioversion has multiple different applications, but not in VFib like you're going to see defibrillation done. The one thing about both cardioversion and defibrillation is that you only do them when you have a rhythm. You will see on TV that they'll defibrillate asystole all day long on those television shows. That's completely wrong. You don't defibrillate it when you have no rhythm. Your reason for defibrillating is to stop the rhythm that you have so that the heart can take over and start again. So if you don't have a rhythm at all, there's nothing to defibrillate or cardiovert. So just know that's a misconception I see a lot just from television. They defibrillate everybody. It's scary. So some people get implantable cardioverted defibrillators. These, if they've got some kind of cardiac issue that makes them prone to life-threatening ventricular arrhythmias, they place the pulse generator. It's implanted just over the upper chest, and just sort of like in the same spot as a pacemaker, and it will fire if they go into VTAC. It's generally a much smaller amount of electricity than when we do an external defibrillator, but they still feel it. They feel like they've been kicked by a mule sometimes. But it is very secure and very comforting for them to know that if they do have those arrhythmias, that their automatic defibrillator will kick in. These devices can also initiate overdrive pacing of supraventricular or ventricular tachycardias, and a lot of times that's why you'll see these people who go into these fast rhythms, and the defibrillator can overdrive. It can also be a backup pacemaker. And this is what it looks like and where it's placed, just so you kind of know what it looks like. People can also have a pacemaker placed. It can be a single chamber or a dual chamber. Dual chambers pace both the atrium and the ventricle. They basically take the place of the SA node. Some of them are, they'll set a rate on these when the pacemaker will kick in. And some people basically it's pacing all the time because their heart does not stimulate a beat anymore. But these are miracle devices, and we don't think of them that way now because they've been around so long. But back in the day, just as recently as I think the 60s is when pacemakers were invented, and people who used to die live for years and years with very high quality of life. So you can have either a pacemaker that just paces the atrium, one that just paces the ventricles, or you can have one that paces both. something I read recently that it doesn't really have to do with class, but it's kind of interesting. If any of you know who Jimmy Stewart is, he was an actor for many, many years, a very, very interesting man. Also was a retired military person, was quite a war hero. He died because refused a pacemaker. I think he was in his 80s, and he just said, you know what? He had one, but he decided he didn't want to get the battery changed, and he was just going to let nature take its course, and uh, and that's how he died. And it's really interesting because we think about that with people coming off of dialysis or refusing chemotherapy, but it's rare that someone says, no, I don't want my cardiac pacemaker battery renewed. That's pretty brave. So I mean, we really have to be aware that these are miracles, and these types of things are why our life expectancy has increased so much. So this cartoon is no joke. I had to laugh when I saw it. You can actually mimic VTAC by tapping on your uh, your leads, and that used to be a joke when I was new that people would pull on me, and I fell for it every time. Uh, so don't fall for that. Thanks, you guys, and I hope this helped. I know it was a lot, um, but go back and read it again. And also, I'll see you in class and we can go over any muddy points. Thanks, guys.